this week on the BackTable podcast.
We just started to conduct this trial. And in UK, there are several trials for the GAE using the NextFear F in the randomized sham control trial in the multi-center one is already began. And also for the US, their gravity trial that is mainly conducted in the UCLA, Dr. Padier, he already started this trial, comparing the GAE and steroid, intra-articular steroid injection. I think these are very important to show the benefit of this procedure.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. Joining me today from Tokyo, Japan, is a very special international guest, the esteemed Dr. Yuji Okuno. Dr. Okuno, thank you so much for taking the time to join us.
Thank you so much for giving me this opportunity.
But it's an excellent opportunity for us, for me to be able to pick your brain and for our audience to learn about the whole world of MSK embolization, which has really been gaining a lot of interest and a lot of popularity over time. Very exciting time to witness kind of emerging clinical treatments. And so, of course, for those who are not familiar with your work, could you just give our listeners a little bit of background about your current practice, your focuses, and what was the origin to treat musculoskeletal pain with vascular embolizations?
Thank you, Jakobs. So I have started this practice from 2012, 13 years ago. So at that time, I was an interventional radiologist and doing lots of practice about interventional oncology and using a catheter to deliver the anti-cancer drug or the embolization for the cancer, the tumor vessels. So we noticed that not only tumor tissue, but also inflammatory tissue has also contains lots of abnormal new vessels, which is induced by inflammation, not due to the cancer. So we noticed that embolizing such vessels can reduce the inflammatory tissue, inflammatory intensity. So it was about 2008 or 2009. Firstly, I had idea that inflammatory vessels, embolizing inflammatory vessels can reduce inflammation. Was that, and from that, I have started the animal experiment or basic research about such idea, and we have started the clinical trial from 2012. So 13 years ago. And now I opened my own clinic from 2017 in Japan. That is OBL, focus on the embolization treatment for musculoskeletal inflammation. Firstly, we focus on the inflammation like frozen shoulder or knee osteoarthritis or overuse sports injuries, including tennis elbow or Achilles tendinopathy or jumper's knee. So we noticed that this condition is a good indication. And now we open our clinic and especially focus on the treating inflammation, especially the chronic joint inflammation, including those conditions.
It's fascinating, and I admire so much how you've had the drive to not only develop a clinical practice based on these emerging treatments, but you're pioneering the basic science research as well. And could you tell our audience just a little bit about some of the research discoveries that you and your group have made and a little bit about your ongoing clinical trials?
Yeah, thanks so much. So from 2008 to 2012, we focused on the research about the difference between the normal capillary, normal blood vessels, and the abnormal blood vessels, like tumor blood vessels or inflammatory blood vessels. So we study about this difference, and we revealed that some genes or some protein that that contribute to the maintenance of the abnormal neovessels. And we noticed that abnormal vessels like tumor vessels or inflammatory vessels have a significantly lower ability of recanalization compared to normal vasculature. Normal vasculature can canalize even though they suffer from such a temporary embolic event, like using a temporary embolic material. The normal vasculature can recanalize, but tumor vessels or inflammatory vessels cannot recanalize after the 10 minutes or 20 minutes of temporary embolic phenomenon. So we noticed that not using a permanent embolic material, but using a temporary material, we can reduce the inflammatory vessels. That is an important idea or important finding we found at that time.
It's a crucial idea, I think, and it's really opened the door towards all these treatments, and those who are outside the realm of interventional radiology particularly can have a little bit of a hard time grasping the utility of embolization for doing anything other than stopping bleeding, which of course is something we use it for often. This idea of the differential recanalization is so fascinating, and I think it's something that the interventional radiologists who are starting to build a practice with GAE and similar things, it's something that I think is helpful to be able to explain, for example, to our orthopedic colleagues. I've heard some pushback on the idea of GAE saying, oh, aren't you just going to cause necrosis in the knee? And so it's really this idea of the difference between these abnormal neovessels and that proliferate this inflammation. It seems like these inflammatory conditions, which even so-called run-of-the-mill osteoarthritis has an inflammatory component. It seems to be sort of a vicious cycle where the inflammation causes ingrowth of vessels and the vessels cause more inflammation. Is that somewhat correct?
Yes, exactly. So there is such a negative feedback. So if the pain occurs, the nerve fiber release the protein or peptide, which can dilate its vessels, nearby vessels, and that maintains the vessel's condition abnormality. And the abnormal nerve vessels release many hyperpermeability and lots of inflammatory cells go outside from the abnormal vessels and maintain more higher intensity of inflammatory condition. So there is some negative feedback or malignant cycle. Yeah. And it's important to, when we induce this idea to other specialty like orthopedic surgeon or pain physician, it's important first opening by the acknowledgement, such a acknowledgement of such a concern about first I heard about the idea of embolization for knee osteoarthritis. It seems very dangerous, or I didn't agree in the first time. Well, we can open the talk about such acknowledgement, and but after that we can emphasize that. But we notice that this is a temporary or minimally embolization technique, and to reduce the blood flow to abnormal inflammatory vessels, and to try to normalize the blood flow or such a thing is very important.
Very important.
Yeah.
And speaking of the temporary embolization process, your work is well known among many for a very kind of novel use of embolic material, which is not used here in the U.S., which is imipenem and celastin. So essentially using antibiotics as embolic material. This is fascinating to me. And could you tell us a little bit of why that choice of such an agent? What are the specific properties?
Thanks so much. So at that time, 2008 or 2009, or imipenem was also used as temporary embolic material in off-label use in Japan, because there is several reports about the imipenem off-label use as a temporary embolic material from 1990. It was already past 20 years that it was used as an embolic agent for the tumor bleeding from the intestinal tissue. Because sometimes cancer patients have bleeding from intestinal tissue, and we cannot find the bleeding spot. So we cannot use coil, or we cannot use liquid embolic material because we cannot find the bleeding spot. So we have to shower from the proximal point, and imipenem can shower even though the intestinal tissue, normal intestinal tissue, we do not make the infarction to the intestinal tissue. So we know that imipenem has a temporary embolic effect, and we induced this material was first because we know the safety profile of that embolic material.
Very interesting. And some of my colleagues who I've introduced this idea to, they perhaps logically, one of the first questions they ask is, are there any untoward side effects directly injecting an antibiotic into a given region?
Yeah. So we don't know such a side effect for persisting a long time, but using imipenem to directly to the intra-arterial. I don't know so far such a specific adverse events regarding to the intra-arterial infusion of imipenem.
It's very interesting. And again, this is one of the things that is so interesting in our community of interventional radiologists, our global community, is happens again and again over the history of the specialty, is taking something that's used for something else and using it for a totally different purpose and creating a new paradigm with that. And now more recently, you've been doing quite a bit of research with different types of temporary embolic agents, and that has led to really multinational clinical studies, including Europe and in the US. And so for those of us who don't have imipenem on the shelves as an embolization agent, can you tell us about some of these newer and emerging temporary embolics?
There are several alternative to imipenem now. So first is a gelatin-made sphere-type embolic material. Then the product name is NextSphere F. NextSphere is made by gelatin, and we can arrange the degradability by changing the density of cross-linking of the gelatin. So gelatin product is have a different density of cross-linking. If the density of cross-linking is high, the water molecule or enzyme cannot reach to the material, so the degradation time becomes longer. And if we reduce the density of cross-linking, so it's much easier for them to reach, and the degradation time will become short. So the NextSphere F is designed to resolve within 8 hours, 4 hours to 8 hours. The mean size is about 250 or 300. That is the design of the NextSphere F, and we found that we used over 800 patients using this particle, and that works well and very safety. The second one is liquid embolic, like Lipiodol is very known embolic agent, and we mix with contrast and Lipiodol and infuse them. It actually a short-term temporary embolic also works well. So some university hospital or academic institution have already started the prospective trial about Lipiodol to use this joint disease. We call it the Lipio joint project. We recently developed the glass beads made by glass, which is also temporary embolic, like 30 minutes or 1 hour. And this glass piece is X-ray visible and ultrasound visible. So we can, after procedure, we can trace the particle degradation by using ultrasound follow-up or the imaging follow-up. That is a new product. The product's name is Novasphere. That is relatively new. And the other one is Sakura Beads, is made in a company in Ireland, which is also a temporary sphere-type microscope. So, and also we have embolic material made by starch. So there is a product, the name is Embocept, or the starch product. That is also a candidate, but size is very small. The 50 micrometer, the mean size 50 micrometer. 50 micrometer is too small. It sometimes damages the nerve tissue, peripheral nerve tissue. So we don't recommend to use smaller than 100 micrometer. The larger than 100 micrometer is better.
Thank you for that overview. And with so many potential options available or coming available, how do the interventionalists go about deciding their approach? And you also mentioned your technique involves kind of the proximal showering. There are, of course, different schools of thought about, being more selective. And can you tell us perhaps just a little bit about your specific approach and what you see as an ideal approach towards choosing the treatment path for the patient?
So important thing is to reduce the side effect, non-target embolization. If we use a permanent microsphere, even though a temporary but still have risk of non-target embolization, we have to be very careful not to infuse or not to reflux the particle to the peripheral tissue, fingertip or some peripheral tissue. So we have to be careful and super selective and as makes the catheter tip as near as possible to the target lesion. But sometimes it's very difficult. For example, the Achilles tendinopathy. Considering the Achilles tendinopathy, the main target vessels is arise from the main artery of posterior tibial artery or peroneal artery. But it's the vessel is very small. The branch is very small. So we cannot select, sometimes we cannot select each branch. So sometimes we have to shower from the proximal point. At that situation, we cannot use a permanent microsphere, of course. So we have to select, sometimes we have to select each situation. And if we know that temporary embolic material do not induce significant non-target embolization, so we can shower from the relatively proximal point at that time. But if we can do the super selective embolization, it's better to do such a method.
Sure. And I read with great interest a recent publication from your group about the posterior tibial embolization for plantar fasciitis. And this was just an incredible paper. Every once in a while you read something that is somehow simplifies the problem so much. And plantar fasciitis is one of these very difficult problems that doesn't have at this time a lot of great treatments. And just to summarize my understanding for our listeners is that you described the ultrasound guided antegrade puncture of the posterior tibial artery and using this proximal technique. And the paper even described the costs for the equipment, and it was staggeringly low. So very impressed by that. And I got a lot of excitement because I have a family member who's struggled with plantar fasciitis. And so start to think about having this available. Anyway, could you tell us a little bit about that project?
Yes, thanks so much. So firstly, we induce a super selective embolization from puncture from groin and inserted microcatheter, angiocatheter, microcatheter to the posterior tibial artery, and sometimes select the small branch from posterior tibial, or sometimes shower from the main trunk of posterior tibial artery, and it works. But usually, as you mentioned, this plantar fasciitis is very difficult condition, challenging condition, and many patients require the second treatment, so 2 times treatment, or some patients require 3 times. So we notice that if we can reduce the cost of time, cost or resource of our physician, or the irradiation of the catheter treatment, or it should be better for the additional option. So we first get idea for the patients, such patients who have already received first time super selective embolization, and their pain reduced 50%, but still have some pain. So we want to do the additional treatment option was ultrasound guided puncture and infusing the imipenem from the point. And we noticed that it works well. The efficacy was similar to the super selective or catheter treatment. It was 4 years or 5 years ago, and since then we started to change our protocol. The first line treatment is ultrasound guided puncture treatment, because in Japan the patients have to pay themselves about the total cost of the procedure, so much cheaper and much shorter time. So we changed our protocol, and now we do the first line treatment for the ultrasound guided only, not using fluoroscopy. And it takes 1 minute or 2 minutes. And
very exciting.
Yeah. And it opens a new door. And it's not only the interventional radiologist, but also other physicians can do this procedure. So some orthopedic physicians who do not have strong interest to our super selective treatment because they cannot do such a skill, so they do not have such a equipment. But for the ultrasound puncture method, they already have good ultrasound machine and skills about ultrasound guided techniques. So some physicians in Japan have already studied this technique, and they notice that this works very well. So we notice that these things is good for makes them understanding or makes them notice about this procedure or this idea is safe and effective.
And it increases, as you're saying, the adoptability, and I think takes it from something that's a little more arcane or esoteric, the idea of catheter-based super selective embolization, to something that can be done in an office for a condition as prevalent as plantar fasciitis. I think these are the type of advancements that can really change not just the face of our own specialty, but of musculoskeletal care in general. And that's what makes me very excited about this. I think there's a lot of potential for population health benefits. And we're still at the phase where, as you said, in your system in Japan, it's a cash pay system, and we are navigating these waters in the US mostly with research, clinical trials, but it's becoming more prevalent. It's starting very, very steadily getting out to the mainstream. And of course, the biggest foothold, so to speak, has of course been genicular artery embolization, but obviously that's growing. And so in the US, we're starting to hear more about frozen shoulder embolization and some other things. And I've just been fascinated with your work, the array of conditions that you've treated. And you've mentioned some of these epicondylitis and Achilles tendinopathy, very common but very difficult things to treat. And even read some of your cases about describing treatment of facet arthropathy, which is fascinating. And I'm used to, of course, treating that with injections and nerve ablations, and really interesting to think about this totally new modality potentially coming in. And I've seen quite often that there is a severe inflammatory component of that arthropathy. And so I found that fascinating. And so all this kind of setup, what I did want to ask was, GAE has gained a lot of popularity. And what do you think will be the next expansions outwards from GAE for adoptability? What will be the conditions most commonly treated next?
Yeah. So I think the one is overuse sports injuries, including tennis elbow, jumper's knee, Achilles tendinopathy, plantar fasciitis, and others. These are very common. Also, the other specialties like sports physician or orthopedic surgeon, they are also seeking some new idea, because standardized therapy is like rest or physical therapy, stretching or shockwave or PRP. These are sometimes effective, but not having a higher reliability. So from our experience, embolization procedure for this condition has higher reliability compared to the other standardized therapy. So higher reliability means many patients have improvement and they don't waste time for the non-effective treatment. Yeah, because sports injuries are many young athletic patients who want to recover or return to their practice or game as soon as possible. So they don't want to waste a long time for the non-effective treatment. So I think it's both injuries, and also interesting thing is that reducing abnormal vessels can accelerate the healing process. So it means that abnormal vessels invasion can disrupt or interrupting the healing process. So reducing the inflammatory can accelerate the normalizing of tissue. So we don't have, so far we have treated more than 1,000 patients of sports injuries, but no one have results in a rupture of the tendon or other ligament. On the other hand, the steroid injection, local steroid injection have resulted 3 to 10% risk of tendon rupture. So it means that, embolization procedure is much safer and good for the healing process. Some sports physician claims that increased blood vessels is trying to heal the tissue. So do not embolize, do not block that blood vessels, because this blood vessel is always good for the healing process, but it's just a believing. And if we reduce the invasion of abnormal vessels and normalize the blood flow, it's a tissue healing process is accelerated. It means that inflammatory vessels invasion stopping or interrupting the healing process. That is the important things. And the other condition is like frozen shoulder. The frozen shoulder is also a good condition to do the embolization, but we have to notice that in frozen shoulder, some vessels is arise from the subclavian artery, and which is near to the central nervous system. So we cannot use a permanent microsphere. So we have to use a temporary embolic material. So that is an important point, but it's also a frozen shoulder is also a good condition to the future.
It's an excellent one. Everyone I've known who's struggled with it has described it as extremely difficult. And it's just, there aren't a whole lot of therapies available for it that are reliably effective, which similar to what you said about a lot of the sports injuries, a lot of further available things that have come out in the last few years, the ubiquitous popularity of PRP and other orthobiologics. Shockwave has seen a lot of acceptance as well. And I've known patients who've done very well with those treatments. And then, of course, we hear about the treatment failures. And that's what's so fascinating about this whole field of hypervascular musculoskeletal connections. And the other idea that got me thinking of is most of the people listening to the show, not all, but most are radiologists by background like you and me. And so we've grown up and we've learned to think about problems in terms of imaging. And so you've described various and sundry conditions and even some more specific things like such a specific facet joint and that kind of thing. How are you approaching the diagnostic aspect for a patient who comes to you in terms of figuring out what their pain generator is?
Yes, thanks so much. So it's very important. So in our practice, imaging before the embolization treatment is very important part. So essential. We basically do the ultrasound or MRI examination before the procedure. We confirm the finding of hypervascularity related finding like edema or effusion or sickness or increased color Doppler signal, or sometimes we use a contrast and contrast enhance in the MRI. This finding is related to the hypervascularity, strongly correlation. If we found the hypervascular findings, such a find, it's promising we can see the brush in the angiography, and the results is also good. Many patients come from the heel pain for the heel pain or Achilles tendon pain, but some patients do not have thickness of plantar fascia or increased. Some patients do not have increased Doppler signal in Achilles tendon. In those patients, do not have a high reliability of effectiveness of the embolization. We include the patients who have hypervascular finding, and we sometimes exclude the patients who do not have abnormality in imaging. So the imaging and identifying the possible pain generator is very important.
Mm-hmm. Yeah, absolutely crucially important. And I love the case reports that you put out, and I've really learned a lot about reading about these and seeing the imaging findings. And it never ceases to amaze me how helpful just some increased stir signal, some edema can be to figuring out what's going on. And I love the idea of using ultrasound as well. And are you using just a typical Doppler or any contrast enhanced ultrasound or anything more specific for identifying vascularity?
Yeah. So we use color Doppler signal. We want to identify the blood flow or the slow blood flow. So the machine is our setting of ultrasound machine is focused on the relatively slower blood flow to identify those signals. So that is important. We usually do not use contrast for the ultrasound, but sometimes the patient do not have a hypervascular finding. Maybe we consider to use contrast to depict the abnormality.
I'm very interested in your practice, and I believe that you have intentionally or otherwise sort of put out a paradigm for treatment of these musculoskeletal conditions. And so you've done a high volume of procedures across many different conditions, and you've even treated high-level athletes, Olympians, and things like this. I would like to hear your thoughts just about the generalizability of this very specific practice you've built.
We're interventional radiologists, so we know about this technique, and but in future we want to generalize this procedure for the many people, the many other expertise. So it's important to do the comparative study between the standardized therapy and GAE or standardized therapy with embolization for the plantar fasciitis, and shows how the benefit of this procedure or the cost effective and also the safety data is very important to generalize. And also important make this idea more easy to understand, because it seems outside of the usual context of the usual thinking that blood flow always contributes tissue healing, but it's not correct. Some blood flow is, of course, contribute to the healing process or physiology, but some blood vessels is not normal vessels, abnormal inflammatory vessels causing a problem. So it's better to reduce these problematic nerve vessels. So I think the words like problematic blood vessels or the abnormal vessels is important to announce that there is a two type of abnormal blood vessels: normal physiological blood vessels and problematic blood vessels. So that is such a thing is very important for generalizing.
Yeah, absolutely. Very, very, I think it's probably the crucial idea in understanding this. And as we've discussed, there have been a couple almost paradoxical kind of aspects of this idea of the differential between the abnormal and the neo blood vessels, the idea that you can shower proximally and it actually be safer. And so there's a lot of kind of preconceived ideas that we'll need to be acquainted to this notion. And I agree. I think that is a challenge. And you've had many years of practice explaining this to world experts and patients and other physicians. It gets difficult, I think, to explain it to a lay person and not talk about cytokines and things of this nature. So as you said, actually, it's going to be the clinical data that the proof is in the pudding, so to speak. And speaking of that, can you tell us a little bit about what are some of the latest clinical studies you and your group have been working on.
We are planning to conduct the comparative study between for the overuse sports injury, comparative embolization treatment and other treatment option. We just started to conduct this trial. And in UK, there are several trials for the GAE using the NextFear F in the randomized sham control trial in a multi-center. One is already began. And also for the US, their gravity trial that is mainly conducted in the UCLA, Dr. Padier, he already started this trial, comparing the GAE and steroid, intra-articular steroid injection. I think these are very important to show the benefit of this procedure.
Absolutely. Well, it's a very exciting time to be involved and just to be interested in all this. It seems we're hearing about new exciting developments all the time. So truly getting to witness the vanguard of, I think, musculoskeletal medicine and the potential future as well. Very, very exciting. And with that, Dr. Okuno, there's nothing else I would like to ask. It's been a fantastic conversation. I want to ask, is there anything else you'd like to share before we end?
Yeah, recently we are now collaborating the company or clinics in podiatry clinics in Chicago. So maybe in near future, maybe this year or next year, we are planning to start the practice in US in the foot clinic, collaborating with a foot surgeon clinic and introducing such a plantar fasciitis or Achilles tendon pain practice in your country.
Very exciting. Well, good luck on that. And we look forward to hearing about it again, talking about establishing new paradigms for treatment. Very exciting times. Well, Dr. Okuno, thank you so much for taking the time to join us. I know we have a very significant time zone difference. I've had a fantastic time speaking to you, and I know that our audience will enjoy listening as well.
Yes, thanks so much.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.